Good afternoon, everybody. I think we'll get started right on time. It's just I have noon. So my name is Paul Helft, and I'm the director of the Charles Warren Fairbanks Center for Medical Ethics. It's my pleasure to welcome you to our monthly lecture series. We've been conducting this series for the past 7 or 8 years on various topics relating to clinical ethics. This lecture is being recorded and broadcasted, and I wanted to thank those of you who are joining us from IU Health Methodist, Northwest, Arnett, and Ball Memorial. And just a quick reminder to silence all of your electronic devices. The phones here, it's actually difficult to get a signal, I think, for some here, but the phones are just outside in a private room across the hall. So it's a great pleasure for me to introduce my colleague, Susan Hickman. Dr. Hickman, you can see all of her many titles. She had to actually abbreviate that list because she has so many. And I'm not going to embarrass her by going through the very long list of incredible accomplishments that she has in her career, but I wanted to say a few things about her. She is a clinical health psychologist by training, went to Wellesley College in Massachusetts, and then got her doctorate from the University of Kansas, and then ended up in Oregon for about a decade or so, where she worked closely with the Oregon Health Sciences University Center for Ethics, among other things, and did much of the fundamental work on the PULSE form, about which she's going to talk about the adaptations here in Indiana. Susan, if you get to know her, is not only a brilliant psychologist, and I always worry that I'm being analyzed when I'm in discussions with her, but is a tremendously accomplished researcher, and one of the most fun things is that if you ever get a chance to study with her, analyze a data set with her, you will find her mind to have an amazing perspicacity. So anyway, it's a great pleasure to be a colleague of hers, and I want to welcome her, and I'm really looking forward to your talk.
Thank you, Paul. Well, good afternoon. It's really my pleasure to be here today. Thank you so much for coming, and for those of you at the remote sites, really appreciate the opportunity to talk with you about the new Indiana Post program. And I'm going to start by just reviewing the objectives for today. We're going to talk about the new program and how the Post is different from traditional advanced directives and the standard approaches that we're accustomed to. We'll talk about key elements of the Indiana Post form as well as aspects of the law. And then we're going to go through a few scenarios to give you a sense of how this actually works in practice. That's one of the key questions I receive when I talk about this is what does it actually mean, how we're actually going to use it. So I'm going to give you some examples, and we'll work through those together to think about how you would incorporate this into a plan of care. Now, most of you are likely familiar with the traditional approaches that exist for documenting patient treatment preferences. And really, the primary one people think about when they think about this topic are advanced directives. Advanced directives really consist of two different kinds of documents. One of them is a living will, which is more of a philosophical statement about your goals, what you wish for in the future. It can be filled out by any healthy adult at any point in time. And really is a statement about what happens if at a certain point in time you are close to death. The second kind of advanced directive is a power of attorney for a healthcare appointment or a healthcare representative appointment. And this is where you identify who you want to speak on your behalf if you're unable to speak for yourself. And the data about advanced directives really is focused in on the living will concept, which is the statement about your goals and preferences. It's really the tool that we use to extend autonomy into the future. And the data suggests by and large that living wills do not change the kinds of treatments people receive at the end of life. There has been a lot of effort invested in promoting the use of advanced directives. Use continues to be poor for both kinds of advanced directives. The documents are often difficult to access. And when you talk about applying a living will in the clinical setting, it can be really challenging to interpret that and apply it to the circumstance that's right in front of you. It's not always clear what it means. So there are often phrases like, if I'm close to death, and what exactly does close to death mean? You'll find that there's quite a bit of variability. I often do a poll, and I find that I get estimates from 6 months to 2 days. So people have very different interpretations. These differences in interpretations extend into the clinician population as well. So we have lots of different ideas about what to do with these documents when they actually even exist. So an alternative that a lot of people have come to rely on is code status. And code status really is about preferences for cardiopulmonary resuscitation documented in the form of a medical order that can be followed in the hospital setting. There are out-of-hospital versions that can be followed in the out-of-hospital setting. And code status, it really just addresses this issue of resuscitation. However, since it's often the only piece of information we have about a person's preferences, it tends to be overgeneralized. People tend to want to use it to guide their decisions about other kinds of treatments. Additionally, it's a tremendous oversimplification of the myriad decisions that are faced by people in the final months of life. There are lots and lots of decisions that need to be made, and code status really does not help you in that situation. Code status is really about what happens at the time that the person's heart stops and they're no longer breathing. And that, basically, what do you want us to do when you die? Do you want us to attempt to restart your heart and revive you? And in many cases, we're not going to get too into this, but that's put out as a choice, as if it's, starting a car engine, when in fact the data suggests that the success rates of code status in the hospital are about 17%. That's been consistent over many, many years. In the out-of-hospital setting, particularly the nursing home setting, the success rates are about 3%. So when we talk about code status, it's, yes, it is a tool, but unfortunately it's not terribly helpful for most of the kinds of decisions that we're faced with. So the POST program, or Physician Orders for Scope of Treatment, was designed really as an alternative to these traditional approaches. And the goal is to document preferences for a range of medical treatments in the form of actionable medical orders that can be followed throughout the healthcare system. It is designed for people who have advanced chronic progressive disease or frailty or terminal conditions. In contrast, anyone can have a living will. Actually, everyone should have a living will and a power of attorney for healthcare. But the POST is really a specific tool for people with serious illness. It allows individuals to document their preferences to either have or decline medical interventions. And I think this is a real strength of the tool because it allows people to document preferences to have interventions, not just to withhold. And it is designed to transfer across treatment settings with the patient so that you have a tool to facilitate smooth transitions and continuity of care throughout the healthcare system. And finally, it's documented in a recognizable, standardized form so that when an emergency medical responder shows up at a nursing facility and sees this pink piece of paper, they have confidence that it is the form that they're used to seeing, that they've been trained on, that they know what the language means and how to apply it, instead of having 30 different versions for every nursing facility they visit. POST is really a communication tool. As I alluded to, it's really about transition care, about ensuring continuity of care throughout the entire healthcare system. So it includes communication among all these players who need to be on the same page about the plan of care for that patient in order to provide care that's consistent with their preferences. So we have at the top, we have the patient. You could actually add their family to that box as well. Long-term care setting, hospitals, clinics, emergency medical responders who really are, frankly, a linchpin of this system, and then the primary care provider. The goal is to have documentation that can be understood and used by all of those players within the system, instead of special forms in each individual location. Now, the POST is based on a model that's really used quite broadly nationally, and the national acronym is POLST, Physician Orders for Life-Sustaining Treatment. I'm using POST in most of my slides here because that's the language we've chosen to go with in Indiana, Physician Orders for Scope of Treatment. They are the same thing. It started in the state of Oregon almost 20 years ago, and since that time, use of this model has spread. Over 20 states have active programs. Most of them have legislation that supports those programs, and almost every other state in the country is working on developing programs based on this model. This is a map from the National Pulse Paradigm Task Force, and you'll see they they've categorized the states based on how far along they are in the process of implementation. So the dark pink states are Oregon and West Virginia, and those are the longest users of the model, and they're considered mature. And then the darker pink states have endorsed programs. These are states where it's fully up and running. They're operational. This is the standard of care in that state. And they have fully functional programs. The lighter pink states are at various stages of development. You'll note that Indiana is pink as well. And then the white states are states where there's nothing happening. I'm not even sure this is fully accurate because I was recently on a call with folks from Nebraska, and Nebraska looks white on this map. So I think it's actually even the smaller number of states that are not working on this. And the interest is really driven by multiple considerations, including a general recognition that our traditional approaches to advanced care planning are not working. And POLST has been identified as a model. The National Quality Forum has identified it as a preferred practice for palliative and end-of-life care, and we're really seeing an interest in trying to adopt this model within each individual state to enhance the goals elicited or outlined earlier. Now, I actually presented as part of the noon lecture series for the Fairbanks Center when I first arrived in Indiana a couple years ago, and actually it was in February of 2010, and I presented in this same auditorium. And at the time, I sort of gave this presentation about the background and the data, and one of the things that I've done, which I'll talk about in a minute, is a legal review. And I sort of, arrived at the point that, well, this is really nice, but it's probably not ever going to happen in Indiana. And after that presentation, I had several people approach me and say, you know what, we're really interested. A group from the Bar Association was actually already talking about how to make this happen. There were clinicians from other hospitals who were really interested. And we ended up getting together and working on developing legislation within the state of Indiana. One of the reasons I was initially so skeptical is that I had previously done a study with the American Bar Association and the West Virginia Center for End-of-Life Care, and we looked at the laws in every single state. We looked at where there were legal barriers or situations where POLST could neatly nest within the existing statutes. And one of the states that we identified as having some particular challenges was the state of Indiana. At one point, we actually had highlighted those states in pink. And the reason that we had identified Indiana as particularly a challenging state to develop a POST program was that we had existing out-of-hospital DNR order statutes that were very, very specific. The Indiana out-of-hospital DNR statute has medical preconditions. In order to have an out-of-hospital DNR, you have to be certified by a physician as having a terminal condition or being unlikely to benefit from cardiopulmonary resuscitation. And it even says much more elaborate language about after repeated attempts it would not succeed. And it required 2 witnesses. And most problematic is that the language of the out-of-hospital DNR form was statutorily prescribed. So if you go to the out-of-hospital DNR statute, you will see the form in the statute. It is embedded in there, so you can't make modifications. It's not that they're key elements that you want to pull forward. They actually prescribe what that form should look like. And that is entirely incompatible with having an easy-to-use 2-page document. So that was one major challenge that we had identified in the review of all the laws that was published in the Journal of Law, Medicine, and Ethics. And in all honesty, one of the other barriers that we did not completely catch on to was that there's an additional challenge, which we discovered pretty quickly in the process of working on developing the Indiana program, and that is the fact that Indiana's default surrogate statutes in the Healthcare Consent Act actually do not specify a hierarchy of people. So if you haven't appointed a healthcare power of attorney or a healthcare representative and you have some sort of medical crisis, every state in the country has some sort of backup system for what happens if those individuals cannot if they're not able to speak for themselves, for who the healthcare team should speak with. In the state of Indiana, we have a list of people that includes the spouse, the adult child, the parent, or an adult sibling. But this is a committee. This is not a hierarchy. So all of these individuals have equal authority under the law. And this actually ended up being a significant challenge in creating the Indiana law. And I will tell you, when I look back on that article, somehow we missed this, because most states, when they have this list, it's a hierarchy. You start with the spouse, you go to an adult child or majority of adult children, and you move on to a parent. They also often have other categories to acknowledge the fact that there may be grandchildren, nieces and nephews, friends who are actively involved in decision making. So this ended up being a significant barrier from a legal perspective that we had not anticipated. So the Indiana Post program was advocated for by the Indiana Patient Preferences Coalition, and this is a stakeholder group that slowly came together over the course of 2.5 years, of individuals who are part of organizations that have a vested interest in this issue, and they include groups like the Indiana Hospital Association, the long-term care trade groups, the Indiana Hospice and Palliative Care Organization, Leading Age, all of the groups that are involved in caring for seriously ill individuals. It also included the Indiana Catholic Conference and the area agencies on aging, and actually it's a very long list. IU Health was well represented on that list of individuals, and this actually became a legislative priority for IU Health both in the 2012 and 2013 legislative session, so we were really appreciative of that support. We did have legislation introduced in 2012. It did not make it out of committee. Nothing made it out of committee that year. As we were testifying, there were people protesting and chanting in the hallways at the State House about right to work, which was kind of surreal. I thought, did they have any clue we're talking about end-of-life care in here? But in the great thing about that is it really allowed us to identify some of the concerns that were still unresolved. So we were able to reconvene following that 2012 session, and with the support and leadership of the Indiana Hospital Association, convened a legislative group to work really directly on some of these key legislative issues. And in 2013, a revised bill was introduced by Representative Tim Brown. He is a physician and emergency medicine physician, as well as a legislator, in 2013, he became chair of the House Ways and Means Committee, so we were enormously grateful for his support because he understood what the need was from a clinical perspective, and he also understood from a legislative perspective about what needed to happen to make this law a reality. The bill was introduced in the House, and the first vote was 99-0. There was no opposing testimony in either the House or the Senate, which is fairly amazing, and it passed the Senate nearly unanimously, 48-1, and then was signed into law by Governor Pence on May 7th. So we now have what I thought was probably never going to happen, which is an Indiana Post program. It is recognized under Indiana law, and the form itself is a state-issued form that is owned by the Indiana State Department of Health. It's available from their website, and they've integrated information about it in their advanced directives brochure as well. So this is now part of the landscape in providing care for patients in the state of Indiana. It became legally valid on July 1st. So some of you are probably thinking, I haven't really heard about this, and that's not a surprise. I get that feedback often. Oh, I talked to this group and they didn't know anything about it. Well, that's going to be part of the process of implementation, part of the process of rollout, and part of why I'm really happy to have the opportunity to talk with you today, because the more people we can share this information with, the greater the likelihood is that we will be able to be successful in our implementation efforts moving forward. So I did hand out copies of the form itself, or there was a stack of them at the entrance. Many of you may have picked them up. I provided copies on the bright pink paper, which is recommended by the Indiana Patient Preferences Coalition. The state health department actually does not recommend a specific color. White copies are valid, photocopies are valid, fax copies are valid, but the pink is really the preferred color because it does stand out. And I look around this room and it's the first thing I see in all of your hands leaping out at me. And that's really the goal, is we want something that's recognizable and identifiable quickly in an emergency situation. So the sections of the form, I'm just going to go over briefly to give you a sense of what kinds of treatments are covered by the post-form orders. For the first section is the section that you're probably most familiar with, and this deals with cardiopulmonary resuscitation. These are orders that are in effect when the patient has no pulse and they're not breathing. This is the what do you do when they are dead, right? So the two orders, the two choices are attempt resuscitation or full code, or do not attempt resuscitation. This is a fairly straightforward category. Most people are used to seeing this. I will point out that it's important you take into account the medical conditions that need to be met in order to honor this. If the patient has a pulse and is breathing or is not breathing, I've been told by emergency medical responders, they do occasionally find individuals who have one and not the other, then you look to Section B. So in Section B, you have orders about a broad category of medical interventions. And I think one of the things that's most helpful about the language on the form is that it includes language about goals of care. And I think for patients and families, this is particularly important. We have under comfort measures that the treatment goal is to maximize comfort through symptom management. The goal here is to do whatever you need to do to relieve pain and suffering. That's an active stance. It's not a passive stance. It doesn't mean do nothing. And that could include transferring to the hospital if comfort measures can't be met in the current location. The second category of treatments are limited additional interventions, and this includes a slightly broader range. It builds upon the comfort measures to include non-invasive airway management. It includes directions to not intubate and transfer to the hospital to stabilize the medical condition. But it does advise that you should avoid ICU care if possible. It also includes IV fluids, which is a particularly relevant issue in the long-term care setting. And then finally, full intervention is basically the standard of care. Full intervention directs that you provide all treatments, including intensive care, all life support measures available. That would include mechanical ventilation, that would include advanced airway interventions, cardioversion, etc. So I just want to emphasize, when we talk about comfort measures, I think one of the things that is really, if you leave here thinking anything, it's that comfort measures is not a passive approach to care. Comfort measures require active intervention. They require active nursing interventions. They require active medical interventions, medications. They require an active approach. And I sometimes, I do hear from people, well, then we don't have to do anything. We don't have to screen for a urinary tract infection if they're comfort measures. And I think, have you ever had a urinary tract infection? They are not comfortable, right? So the goal here is on enhancing comfort. If that means doing a urine screen in order to check whether somebody has a urinary tract infection, then that's what you do. Doesn't mean do nothing. There are situations in which transfer to the hospital is entirely appropriate for patients who have comfort measures or comfort measure orders. One of the studies that I conducted was a study of charts of nursing facility residents in 3 states, Oregon, Wisconsin, and West Virginia. We looked at 90 charts. We looked at 90 nursing facilities, 1,800 medical records, and then we evaluated when people had comfort measures orders and they went to the hospital, was that consistent with that order to enhance comfort? And 92% of the time it was, based on our evaluation of that individual's needs and the charting that was available. And some of the things that we thought justified hospitalization included things like uncontrolled symptoms that couldn't be met in that setting, shortness of breath, pain that can't be managed. Hospitalization would be appropriate. Uncontrolled bleeding, lacerations, fractures, bowel obstructions, wound infections. These are all things that cannot be safely or easily managed in the long-term care setting and require hospitalization in order to stabilize. So you may get patients in the hospital from the nursing facility setting who have comfort measure orders, and I would hope that your first question wouldn't be, why did they make the mistake of sending this person here, right? The question should be, what does this person need? Why are they here? What can we do to help achieve that goal of comfort? The general rule of thumb for this population is no ICU care, although I have talked with physicians. They like to tell me all the exceptions about patients who had to be put in the ICU to receive, methadone. I don't remember all the specifics, but I thought, okay, well, if that's a comfort-focused intervention, great. You have achieved the intent of this order, which is to enhance comfort. There are some orders that are incompatible on the post form. And specifically, if an individual has an order for CPR in Section A, so they want resuscitation attempted, they must have an order for full intervention in Section B. Because in all likelihood, these patients are going to require transport to the hospital and intubation and time in the ICU care post-resuscitation attempts. If they survive that attempt, that is in all likelihood what's going to happen. So you don't want to make the mistake of suggesting to someone, we can attempt to resuscitate you and then we'll just put you back in bed and it'll all be fine. These are people with serious illness. These are people who are frail, people with advanced disease, and it is pretty much medically impossible that you're going to avert an ICU stay for these. Now, there may be one or two cases where that would happen, but generally speaking, you should really let them know that's an expectation. So if they want to be full code, they need to understand that that may well come with the possibility of time in the ICU, and the orders need to reflect that. A post form is not contradictory, however, if an individual is marked has a DNR order in Section A, but they want limited or full interventions in Section B. And I have had a lot of interesting conversations with people trying to help them uncouple code status from decisions about intubation and aggressiveness of care. And I think some of this is some of the residual that previously was the only piece of information we had. And some of it is really encouraging people to step back and think, what is the patient's current condition? Do they have a pulse? Are they breathing? If you answer yes to one or both of those things, you follow the orders in Section B, which could include ICU care if they're a full treatment patient, even in the face of a DNR order. If they don't have a pulse and they're not breathing, then you don't attempt resuscitation. It's a different way of thinking about it, but I wanted to acknowledge that. I think sometimes people want to couple that, and I understand the inclination to do that, but they are two separate issues. The next section deals with antibiotics use, and the orders we have on our form are use antibiotics for infection only if comfort can't be achieved through other means. There are several studies now looking at the treatment of pneumonia in long-term care nursing facility residents, for example, that suggests that you can provide adequate comfort, attention to comfort without providing antibiotics, and there's some situations where that may be a choice that an individual resident or family member would make. Other examples of, uncomfortable infections include things like urinary tract infections, as we already talked about, wound infections. And then the alternative is to use antibiotics consistent with the treatment goals. So you would look back to Section B and think, okay, they want antibiotics, but they didn't want to go to the hospital. So how can we provide antibiotics in this setting without transferring them to the hospital? Is that possible? So you would need to weigh those two goals and figure out how to come up with a plan that's going to achieve both goals, both the intent of both goals. The final section deals with artificial nutrition, and essentially this is not completely unfamiliar to people because we do have some orders or preferences, on the living will about artificial nutrition. But there are three categories. One is no artificial nutrition. The second deals with a defined trial, or allows people to express a preference for a defined trial period of artificial nutrition. And it includes space to indicate the length of the trial as well as the goal of the trial. And the hope is that this will actually promote discussion. So if a person has a stroke, let's say their swallowing ability is compromised, they want a trial of speech therapy, see if they can work with the speech therapist to regain some swallowing capacity, that they may then want to reevaluate, okay, in 2 months, if this isn't better, do I still want a feeding tube? Now, many of them will probably decide yes. But some people may decide at that point in time that they don't want to continue artificial nutrition. The point is to have a conversation about it instead of having a tube placed, leaving it in, and never revisiting the issue. The final option is for long-term artificial nutrition, and these are individuals who, have selected this as a choice for them. If there's been a discussion about the risks and benefits, this is a fully appropriate selection. Section E deals with the patient and representative signature. This is a required element in the state of Indiana. Not every state actually requires the patient or family member signature, representative signature on the form. But in Indiana, we felt like this was a really important element to include. And you will note that it requires their signature as well as to print their name, and then you want to mark who that individual is, so there's clarity, particularly if that is not the patient. You want to make sure it's somebody who's been legally appointed as the healthcare representative, healthcare power of attorney, or legal guardian/parent. Section F is the physician's signature box. The post form cannot be signed by a nurse practitioner or a physician assistant. It must be signed by a physician. Some states actually have allow nurse practitioners and physician assistants to sign the forms. I know that in some contexts that this is a real challenge. In the hospital setting, many of you are probably thinking, what's the big deal? But in long-term care, much of the day-to-day care is provided by nurse practitioners, and so this is a real challenge logistically in that setting, as well as when you think about, what is the meaning of the signature. In all likelihood, in that context, the nurse practitioners had the conversation, but at any rate, at this point, this is where we're at. It does require the physician signature. It also requires their license number, phone number, as well as printed name and date, and I want to emphasize the printing of the name. I have actually seen physician signatures on post forms in other states that I saw one that was a line. I'm not kidding, it was just a line. And I went to one of the nurses and I said, what is this? She said, oh, that's Dr. So-and-so. That's how he signs. I thought, wow, like if you didn't know Dr. So-and-so signed with a line, it would be pretty hard to understand who had actually authorized the orders and executed the form. So there are several questions that we grappled with in developing the program, and some of these we've sort of had hints of them because the decisions are reflected on the form. But one of those key questions was who can have a post form, and we had a lot of discussion about who's eligible, and we ended up with 4 different kinds of patients, although they're not always, they're often one and the same. Patients with advanced chronic progressive illness, advanced chronic progressive frailty, a terminal condition, and I've included the definition of terminal condition from the Indiana statutes, or someone who's unlikely to benefit from CPR. It is void if the patient is pregnant. That is true of all of our kind of advanced planning documents in the state of Indiana. Now, the categories of who can have a post form are a little broader than the out-of-hospital DNR order form, because one of the challenges that clinicians shared is that when they try to execute an out-of-hospital DNR order form, it says right in the form that the patient has a terminal condition. Now, most patients don't particularly like that language, and truthfully, most physicians find that uncomfortable, particularly in diseases where the prognosis is not quite so predictable. So the form itself contains orders that allows patients with a terminal illness or condition to have a post form. And you'll see here what I've provided for you are data from a really large analysis of Medicare enrollees and their functional trajectories in the last year of life. And what you see is that there are some distinct patterns of disease that occur for these individuals as reflected by their functional status. So I wonder if I can get this pointer to work. No, I cannot. Okay, so you have the sudden death trajectory. These are individuals who are unlikely to benefit from advanced care planning. These are people who are functioning really quite highly, who have a sudden event. There really isn't time. Post is really not designed for that population. The second category are patients with terminal illness or conditions. Cancer patients tend to fit this trajectory the best, but really it's individuals who have a fairly high level of functioning, followed by a fairly predictable and steady decline in their functional status. And really when we talk about the previous definition of terminal condition, that tends to fit it, although not a perfect fit. The next group are the organ failure, and this is the group where you have the biggest challenge because it's most unpredictable. These are individuals with heart failure, liver failure, kidney failure. These are individuals with advanced chronic progressive diseases who have recurrent episodes that require hospitalization and intervention. And as their disease progresses, those interventions start to offer diminished benefit, and the burdens of those for many people increase. And you never know at what point in time one of those hospitalizations is going to be a terminal hospitalization. So we wanted to make sure that we didn't ignore this very large group of patients. It represents about a third of all causes of death within the older adult population, because these are individuals who start having questions about, do I want to keep doing this? Do I want to keep going to the hospital? And it is pretty unclear when you're going to run out of options and when that terminal hospitalization will occur. Final group is a frailty group. These are individuals with either medical frailty, advanced dementia, where they may have a very long period of time with very low functional status. So again, when we thought about the categories of who could have a post, we really wanted to be more reflective of how people die. And if you exclude sudden death, about 10% of the population dies from sudden death. The other 90% of deaths are fairly evenly divided between those three categories. So I now feel like we actually have a tool that reflects the reality of how most people die and what leads to their death. Next question is, key question was who can prepare the form? And I want to make a distinction here between preparing the form and executing the form. Although I have people wince when I use that language, that's actually the language in the law of execution. And the form can be prepared by the physician or the physician's designee, and it's up to an individual physician to determine who they feel confident in, who they trust to hold these conversations with patients, because the reality is most physicians do not have the time. And in the long-term care setting, typically the forms are prepared by nurses or social workers who work with these residents. And we know that that's the model that works nationally. These are individuals who are already having these conversations. They're just using a new tool to facilitate those conversations. I do want to make a point that the form should not be filled out by attorneys, patients, or family members. This is not a form you hand to patients, send home with them, and ask them to bring back on their next visit filled out. This is not a form that attorneys should be completing with patients or their clients during estate planning. That's not appropriate. This is a form that deals with medical orders. There needs to be a discussion about risks and benefits. There needs to be a team of people caring for this person who can address those questions if the person who's doing the preparation doesn't have the education or background to do so. It requires the signature of the patient, as I've already said, as well as the treating physician in order to execute it. Another question I frequently get is, what are the obligations of the treating physician who signs the form? They do need to confirm that the patient is eligible. They are a qualified patient under the law. There should be a discussion of the goals and treatment options, as well as completion of the form based on the patient's preferences. And you'll note I have the asterisk there. The designee could actually complete this part of the process. They need to determine the orders are reasonable and medically appropriate, and then sign the form with the required information. If the patient lacks decisional capacity, the form may be completed by their legal representative. That could be their healthcare representative, could be the power of attorney for healthcare, or a court-appointed guardian. One of the things that we did in developing this form is we added the healthcare representative appointment to the back of the form to try and facilitate the identification of a representative for patients who currently have capacity, but we could anticipate they may have a condition where they might lose capacity in the future. A lot of people have not completed this kind of paperwork. This is an opportunity to do both things at the same time. The orders, if it's completed by a legal representative, their responsibility under the law is to base the orders on the patient's express or implied preferences, if they're known, and if not, their best interests. If there's no formally appointed surrogate, we run into a challenge, because as I told you earlier, Indiana's default surrogates are a committee of people, right? There's no hierarchy, so you wouldn't know who to go to. Because of that, there was a concern that there was a risk there'd be multiple competing forms out there with different kinds of orders, that warring family members would end up with taking, mom to different doctors, and we ended up under the law, not allowing default surrogates to complete a post form on behalf of incapacitated patients. So unless they have been legally appointed, they are not authorized to complete this form on behalf of incapacitated patients. For these patients, the out-of-hospital DNR is still an option. Those individuals can actually complete an out-of-hospital DNR. Has that been a big problem with the out-of-hospital DNR? I don't know. I couldn't get anyone to answer that question, but that's where we landed, and that's where we're at. How does post work in the hospital setting? So I want to emphasize this form is valid in all settings. But what that means in the hospital is a little different than what it means in a long-term care setting or for a patient who's being cared for at home on hospice. In the hospital setting, what will happen with the form is when an individual comes into the emergency department with a post, the orders should be used to guide the plan of care and the admission orders for that patient. Okay? You're not going to have this on file in the hospital chart guiding care. And in truth, you don't need it. You want to make sure the goals are reflected in what you're doing, but you need far more specific orders within the hospital setting, and you have the ability to generate those far more specific orders because you could throw a stone and hit a physician, right? Not that I would throw stones at my physician colleagues. But in the long-term care setting, it's a very different story, right? The physicians are required every 60 days to do review of their patients. It's a very different context, very different. So in the hospital, this will guide the orders. This should guide the plan of care, but you're going to have all of it translated into your internal order sets. You're going to have code status that's going to be based on what you saw in the post. You're going to have your decisions about whether this person goes to the ICU or the hospice unit based on the post form. And actually, I just want to note that the orders are valid even if the physician who signed them lacks admitting privileges. So if somebody shows up at the emergency department and the physician who signed the form is not a physician who has admitting privileges, that is not really a relevant consideration. Under the law, the form is valid. Okay? Can the post be overruled? Another key question. Clinicians are required to comply with it unless they believe it was not validly completed. They think the patient has requested alternative treatment or revoked the form. If they think it's medically inappropriate to provide the treatment directed by the post, or if they have religious or moral beliefs that conflict with the post. So these are the only conditions in which a clinician could opt not to follow it. And it doesn't say the physician who signed it lacked admitting privileges, right? So you would need to think, do I have a reason to believe this is not valid? Is the physician's signature Dr. Mickey Mouse? Is the physician's signature the same name as the son who just came in, who clearly is not a physician, right? Those would be invalid orders, okay? I also want to note this issue of religious and moral beliefs. This was a really important consideration that we worked really hard to be attentive to the concerns brought forward by particularly the Catholic, the Archdiocese and the Catholic Health Conference, and we really wanted to make sure that we honored this. However, if this does become an issue that a provider has religious or moral beliefs, they are required to attempt a transfer of that patient to another provider who would actually be able to honor that individual's preferences. How do we handle the form? Post is the property of the patient, and so it goes with the patient. It doesn't end up in your medical records. It shouldn't get sucked into the vacuum of the hospital chart room. The original goes with that patient everywhere they go throughout the healthcare setting. You should keep a copy of it in the medical record. Yes, it's possible that the person will update it and you will have a copy. You are protected. There are good faith protections in the law. That if you act in good faith on what you think is the most recent version, you are protected. Okay? This is, yes, largely a paper-based system, but that reflects the reality that long-term care settings are heavy users, and right now, fewer than half of long-term care facilities have any form of electronic medical records in this country. Use of the form is voluntary, so we should never push or require completion of the post. And if someone refuses, you need to document that, and you shouldn't reapproach unless their condition changes. And always, you should reevaluate these orders when that person's condition changes. When there is a change in the medical condition, it is entirely possible that there'll be a new plan of care that's generated. So unlike an advance directive that is sort of carved in stone, once you fill out a living will, that is it, right? There's one tool, there's one piece of paper, and if that patient loses capacity, you can't go back and change it, right? Only the patient can change it. The post is a medical order set. So as that person's condition changes, it is entirely possible that the orders on that form will change to fit the changing circumstances. So I could, really probably do 2 days of a workshop on the post conversation, and I'm not going to do that here today. But basically, it is important to think about the fact that this is not just a checklist. This is really a representation of the patient's preferences, and therefore it requires a conversation. You need to have a dialogue with the patient, and ideally their legally authorized representative and family, so that everyone's on the same page. You want to understand or assess their understanding of the disease. Do they know what the potential complications are? How are these treatments relevant for their condition? What are their goals? And what are the risks and benefits of making the decisions to be, for example, full code versus a DNR? So there, I did it in a minute, right? You're all ready, right? There are models of education for training people to engage in post-conversations. Respecting Choices is a program out of Gunderson Health System in La Crosse, Wisconsin, and they provide standardized patient education materials and documents, as well as a structured interview for non-physician facilitators to engage in post-conversations. There are 14 hours of required education as part of this program. There are about 6 hours online. It could be up to 10 if you're not very computer savvy. And then an 8-hour in-person workshop. We actually just held our first Respecting Choices post-facilitation training last week, and it was quite an interesting experience. It was a long day. That was actually done in conjunction with a project that I'm part of called Optimistic, which is a CMS-funded demonstration project in which we're working to reduce potentially avoidable hospitalizations in long-stay nursing facility residents over a 4-year period. And this is a really busy slide. When I see it up there, I think, whoa. But I wanted to give you a sense. We have 19 facilities in the Indianapolis area who are partnering with the IU Center for Aging Research, and we are doing multiple interventions to try and reduce of potentially avoidable hospitalizations, and one of those interventions includes using the Respecting Choices post-facilitation model. So as we start doing that in the facilities and increase the numbers of residents with post forms, you are going to see more of them in the hospital side of things who have completed post forms from that project. There are many other avenues through which those are actually getting generated, but I just wanted to call your attention to that. There are lots of next steps for the state of Indiana for us to eventually achieve dark pink status on that map I showed you earlier and to become endorsed states. There's tremendous need for training and education. We do have a guidebook for healthcare professionals and frequently asked questions that's available on our website. Currently the website is housed through the Respect Signature Center, which is an IUPUI signature center. We also have had some success with emergency medical responders. The State EMS Commission recently voted to approve mandatory education for all newly certified and recertifying emergency medical responders in the state of Indiana, starting on January 1st. Now, they have 2 years to complete that, so it's not like January 31st we can be sure that every emergency responder knows what it is. But that's going to be a really critical part of the implementation process. We also have groups working on developing model policies. There already is a hospital model policy that's been developed and vetted by the Indiana Hospital Association, and that policy is winding its way through IU Health and Wishard, as well as other hospitals throughout the state, St. Francis Community, et cetera. We're working on a model nursing facility policy, hospice policy, emergency medical response protocol. And we also have groups in 2 parts of the state who are particularly interested in really focusing and concentrating implementation efforts. There's a group out of Fort Wayne as well as a group out of Bloomington who are working to really do intensive implementation within those regions. That being said, the form is legal across the state, so there are many other places that are starting to use this. But I think it'll be a good 3 to 5 years before we have really a solid program in place where people know what the post form is, they know what to do with it when they see it, and we're really seeing changes in the way we approach care. So how does post work? I left myself 10 minutes. So I just wanted to give you a few examples of scenarios that might come up. And help you think about, what do you do with this bright pink piece of paper when it shows up in your system? So first scenario, an 86-year-old woman arrives in the emergency department with severe shortness of breath. She has advanced diabetes and CHF. Her husband reports she was recently diagnosed with pneumonia. He hands her completed post form to the nurse. It says Section A, attempt resuscitation. Section B, full treatment. Section C, antibiotics consistent with treatment goals. And Section D, a trial feeding tube. So what do you do? I'm hearing murmurings. You have to do it. Well, what do you have to do? You want to assess her medical condition, right? You want to talk to her, right? I didn't say she was incapacitated, right? So this is not a substitute for actually talking to patients. So, sorry. So you want to talk to her, talk to the husband. What are their goals? Okay? Is this still what they want to do? They may show up at the hospital and be like, oh my gosh, we're sick of this. Stabilize her, but oh my gosh, this is getting old. Or they may be like, this is our plan of care. This is what we want. So she might end up in the ICU, right? She might end up on a ventilator. She probably will require a reevaluation of pneumonia, maybe a different antibiotic, right? So you're going to proceed based on those orders, right? And this is somewhat straightforward because this is like if you didn't have a post-form, you would do all that stuff anyways, right? But with a post-form, you have some confidence that this person actually understands what they've agreed to, right? That they have actually had a conversation with someone, that they do want to go to the ICU and be on a ventilator. Now, you personally might not make that choice for yourself, but this isn't about you, okay? This is about this individual's preferences and honoring their preferences. Scenario 2. 84-year-old woman with metastatic lung cancer is brought to the emergency department by ambulance from the nursing facility. Her breathing is labored, and she is moaning in pain. Her medical records include a post-form. It says DNR, comfort measures, antibiotics for comfort, and it should be no artificial nutrition, excuse me. D does not address hydration. So, what do you do with her? You send her right back, say, what on earth did you send her to us for? It says comfort measures. Why did they send her to you? Yeah, she's in pain, right? She's having trouble breathing. They didn't feel they could manage that in the nursing facility. Does that mean you throw away the post-form and send her to the ICU? No, right? This is going to drive your plan of care. It's going to help you figure out what to do with this patient when she arrives. So maybe you can stabilize her in the emergency department. Maybe. And then you could send her back. You might not be able to, so you might admit her to a general medical ward. You might admit her, if you have a hospice or palliative care unit, you might admit her there, right? Or to that service. So this is going to help you better meet her goals. Yeah, thank you for saying that. Because actually I should have said what I said in the first scenario. So talk to her, right? She has capacity. If she's capable of speaking to you, right? You want to affirm, here's what we're planning to do based on what we know about your preferences. Is this what you want us to do? Right? And she might say, no, I really, I've been on the ventilator before, put me on it. I can't handle this labored breathing. Right? Okay, well, you would have a conversation, but she's entitled to change her mind. Okay? So yes, thank you so much for saying that. That's after I already said it's not. You still have to talk to them. That's exactly right. You want to ask her? Yes. You have. Mm-hmm. So what happens if the patient changes their mind? Yeah, you would document it. Now, you would document it in the records like you would document any other conversation you had. If there's a concern that they're actually saying, I should have never agreed to those things on the form, and then you're going to have to revoke the form. And the law actually specifies very clearly how you revoke the form. So you could physically cancel the form by putting an X on it, right? You make a documented note in the chart that the patient changed their mind. This was the circumstances. This is when it happened. Okay. I think it says time, place, and date, and I think place. Okay, place. But time, place, and date is what it says in the law, right? And then you're going to want to follow up with the doctor who signed this to let them know that the post form was revoked. Okay. But just because she requests alternative treatment doesn't mean she's throwing the whole thing out. So I want to make that distinction because sometimes people say, you know what, that's still what I want, but not right now. Okay. Yes. There's no specification about who has to do that documentation, no. Okay. All right. Scenario 3, 59-year-old man with metastatic colon cancers transported by ambulance to the ED with severe pain and a likely bowel obstruction. He has a post, which is signed by the patient and his physician in southern Indiana. DNR, comfort measures, antibiotics, no feeding tube. Can you honor his post orders? Yeah. Okay. So what's the first thing you're going to do? Talk to him, right? We see this post form in your records says that you want comfort measures and DNR, and here's what we can do. Is this still what you want? Okay. Great. That may require possibility of surgery, right, to remove that bowel obstruction. But if that's going to keep him comfortable, that may be where you need to go. Okay. All right. 84-year-old patient with end-stage. By the way, not this specific situation, but I've heard at our last Patient Preferences Coalition meeting last week of a couple of situations where people have showed up in area emergency departments with post forms, and they've been handled completely appropriately. People who would have received full intervention, who would have gone to the ICU, in both cases they had orders indicating they wanted comfort measures, and they were transferred to the palliative care units. So it's working. It's working. Scenario 4, 48-year-old patient with end-stage renal disease was recently admitted to the ICU. He's non-responsive on a ventilator and requires dialysis. The family tells the team they want them to do everything. The nephrologist faxes in a copy of a validly executed post form she completed with the patient. That says DNR, comfort measures, antibiotics consistent with treatment goals, and a defined trial period of a feeding tube. What do you do? Yeah, you're going to have to sit back down with the family and say, his doctor just sent us this form. Did you know about this? Did you know he'd had this conversation with his physician? Were you aware that these were his preferences? What do you understand about these? What do you think this means in the current situation? Do you have any reason to think that this isn't what he wants anymore? Right? You're going to have a conversation. And probably call an ethics consult if they right? Yes. So in that situation, what does the law tell you? It tells you that if none of those people were legally appointed as a healthcare representative, power of attorney for healthcare, or guardian, you need to follow the post. So a healthcare representative could potentially say they no longer want to follow the post, but they would have to provide you with information that supported that decision, right? Because the statute requires that the healthcare representative make decisions consistent with that patient's known or implied treatment preferences. Do they have some reason to think the known or implied treatment preferences have changed? If so, yes, they could revoke it as the legally appointed representative. But they're going to have to explain that in a way that actually sounds credible, which is where the ethics service probably would be helpful, right? I don't want to give any. Go ahead. Question, John.
There's a statute called the Indiana Healthcare Consent Act, which allows a non-appointed family member to make a decision. I believe there's no hierarchy. Is that Indiana Healthcare Consent Act no longer?
No, that's still valid. The Indiana, yes. So the Healthcare Consent Act is still valid. So outside of the post, if that person didn't have a post, those family members can make all those decisions. So if there's no post here, you're doing everything, right? You're listening to the family. You have no information about the patient's preferences. You listen to the family. If they were not appointed, correct. So if they were not appointed, they still, this is one of the things I think is a little hard to get your head wrapped around, but if they're not formally appointed, they still have the ability to make those decisions if there's no post form. Okay? They can't complete a post form to document those decisions, but they can still make those decisions. But if there is a post form, then it's a different conversation, right? Okay, I'm going to do I've got the same guy, it says do everything, right? So it's some of the same things we just talked about applied. Since we're at Riley, we'll do our peds. 12-year-old cancer patient has completed 2 rounds of chemotherapy, but her brain tumor is unresponsive. Her family declines to pursue further cancer-directed therapy and has expressed an interest and taking her home so she can be in a familiar environment with her pets and stuffed animals. The team is supportive of this plan and arranges to discharge her with hospice. So what do you do? What do you do with this patient? I'm not going to talk about how you get to this point, by the way, how you get to the point in the decision-making process where everyone is in agreement that this is the right choice. But what can you do to support this patient and her family? You would want to fill out a post form, right? Because she's going to go back to her community and be at home. So it's possible she'll be with hospice, but it's possible the family will call 911, right? So you can set them up to have a better experience by having the plan of care documented on the post form and sending that with the patient. Okay? And this would be true even if this was an adult patient, right? So for these kinds of patients, for patients who are getting transferred out on hospice, who are going back to the nursing facility after a really clear and explicit conversation about goals of care and everyone's in agreement, here is your chance to actually see that enacted and followed by getting a post form completed and sent with that person. Okay? All right. You guys are being very patient, but I think we're technically over. So I will happily take, I had a few questions, but I'll happily take a few more for those who want to stay. Yes? Oh, so state reciprocity, we're working on that issue that has come up, but right now, no, there is no state reciprocity. Illinois does have a program. Some parts of Michigan do, but Ohio and Kentucky do not.
But we could safely say it could help guide.
It definitely, you could safely say it would help guide the treatment plan, because I have never met a physician who says, I don't want to know anything about their plan of care, right? I haven't met that physician yet. Gabe, are you going to correct me? Does EMS have protocols for comfort measures? That's part of the protocol development that's going on. So, because this is different for EMS too, right? Because there are situations where they're going to arrive at the scene and they may be able to, let's say the person's out of oxygen. They may be able to give them a canister of oxygen to tide them over until the home healthcare service delivers the next canister and leave without transporting them, which is why EMS is so important. So that is in process. So, okay. So the language about medically inappropriate, is that primarily a futility statement? Yes. That was really the intent. Was around situations where people may have orders and they've expressed preferences, they have a post form indicating full treatment, but it no longer seems medically feasible to continue providing that intervention. That was the intent of that. Okay. One last question. Oh, what happens if a post and a living will are inconsistent? So that's entirely possible, and actually I would argue they're not inconsistent, because when does a living will apply? Right? At the very, very end of life. And the post, we often say the question to help you identify who's appropriate is to ask, would you be surprised if this patient died within the next 12 months? So you may have a patient with metastatic lung cancer who nobody would be surprised if that patient died within the next 12 months, but that doesn't mean the living will is in effect right at that moment. So they may want to go to the hospital still. They may want to try one more round of chemo, and that's appropriate. Those are not inconsistent goals. Right? All right. Thank you, everyone, so much. I appreciate your time and attention.